Great honor and privilege to welcome you all to the special online gathering on the occasion of the Rheumatic Heart Disease Day, observed the 20th June to commemorate the birth anniversary of the true pioneer of Indian cardiology, Dr. S. Padmavati, past president of the Cardiological Society of India. Dr. Padmavati was more than just a physician, she was a legend to us. As the first woman cardiologist to become the president of the Cardiological Society of India in 1965, she broke barriers and paved the way for generations of medical professionals. She was almost synonymous with rheumatic heart disease in India, dedicating most of her life and work to understanding, preventing, and treatment of this condition. For her immense contributions to cardiology and our society, she was honored with the CSI Lifetime Achievement Award in 2011. Dr. Padmavati's impact went far beyond the professional recognition. She was also the recipient of the two of India's highest civilian honors, the Padma Bhushan in 1967 and Padma Vibhishan in 1992, a testament to her unmatched dedication, brilliance, and service to the nation. Today, as we remember her legacy, we also come together with a renewed commitment to raise awareness, enhance early detection, and improve management of rheumatic heart disease, which contributes which continues to affect countless lives, particularly in underserved communities. This afternoon program brings together esteemed speakers and participants who share a common goal to honor the past, reflect on the present, and work towards a healthier future. Thank you for joining us. We are delighted to have your presence and support. Now it is my pleasure to invite the convener of the CSI Rheumatic Heart Disease Council, Dr. Sanjeev Asatra, to deliver the welcome address and set the tone for this meaningful event. Over to you, Dr. Asatra.
Thank you, sir. Hope I am audible.
Yes.
My greetings to one and all. And on behalf of CSA and being convener of CSA Rheumatic Heart Disease Council, I welcome you all to the webcast of rheumatic heart disease. As sir has already highlighted, that this RSD Day is being commemorated as the birthday of Dr. Siva Ramakrishnan Iyer Padmavati, and she was born on this day in 1917 in Burma. She was an amazing clinical cardiologist, and I had an honor of working with her for nearly 2 years in National Heart Institute. And she was trained with the best of hands like Dr. Paul Dudley White and Helen B. Tossings at Harvard and Johns Hopkins. And even in her 90s, she had an amazing clinical skills, and she was ready to teach us all day. And we on this auspicious day, we have two talks by very eminent speakers and great research minds who have really made immense contribution to the research in rheumatic heart disease in last decade in true sense. And we are lucky to have both of them as Professor Karthik and Professor Leslie Zulke from South Africa. And there's a little change. The first talk will be delivered by Professor Ganeshan Karthikan on what we have achieved in this century in rheumatic heart disease, as he has to leave to probably Hyderabad. And second talk will be delivered by Professor Leslie Zulke from Cape Town, South Africa, on global burden of rheumatic heart disease. And we are hoping to hear a great amount of receive knowledge from them. I pass on baton to Professor Sanjay Tyagi, President CSA-elect, to speak on the importance of this day, and then we can go to the scientific session. Thank you.
Thank you. Thank you, Dr. Asatra. Dr. Tyagi, please.
Good afternoon, dear friends. It is my honor and privilege to welcome you all on this important day of rheumatic heart disease celebration, particularly to remember our great Dr. S. Padmavati, who was also the Dean and Director of GB Pant Hospital and Maulana Medical, beside being bestowed with many awards. Talking to you about rheumatic heart disease, as we know, the Epidemiological Association of Acute Rheumatic Fever and Rheumatic Heart Disease with Group A Streptococci sore throat was established in first half of last century. However, rheumatic heart disease still continues to be a significant cause of preventable cardiovascular morbidity and morbidity among children and young adults. It is a sad reality that although eminently preventable, and despite possessing such knowledge for more than 70 years, rheumatic heart disease remains the most common cause of cardiovascular morbidity and early mortality in young people worldwide. A disease of the poor, rheumatic heart disease is one of the most neglected diseases. Several challenges are unique to the acute rheumatic fever, rheumatic heart disease continuum and contribute to its persistence, including its sequestration among the poorest, its protected natural history, the erratic availability of penicillin, and the lack of concerted efforts in the endemic regions. Rheumatic Heart Disease Day is crucial for global health awareness because rheumatic heart disease remains a leading cause of cardiovascular death and disability, especially among children and young adults in low and middle income countries. In large low income countries and low and middle income countries such as India, Brazil, and China, there are sharp regional variations in rheumatic heart disease burden that mirror human development and access to the primary health. It is estimated that more than 40 million individuals are affected with rheumatic heart disease across the globe. The disease claims over 3 lakhs lives annually, with millions more living with the chronic disease, mostly in marginalized and resource limited communities. Despite its severe impact, rheumatic heart disease is often neglected in global health discussions, receives minimal research funding, and suffers from low public awareness. Raising awareness through these dedicated days helps spotlight the preventable nature of rheumatic heart disease, mobilizes resources, promotes diagnosis and treatment, and advocates for equitable healthcare access, steps which are essential to reducing the global burden of this preventable disease. Despite the high morbidity and mortality, rheumatic heart disease has not attracted enough attention among the policymakers and program planners, even in India. Although evidence-based effective prevention and control strategies are available, which can be implemented even in weak healthcare system at low cost. Ideally, improvement in living standards, that is primordial prevention, and better access to the medical care for treatment of group A streptococci sore throat, that is primary prevention, can prevent large number of acute rheumatic fever cases. The prompt diagnosis of acute rheumatic fever and rheumatic heart disease cases and administration of long-acting penicillins every month or every 3 weeks as we give in India can prevent recurrence of acute rheumatic fever to avoid further damage to the heart valves. I would like to summarize that rheumatic heart disease programs such as this highlights important issues, that is raising community awareness about rheumatic heart disease, its causes, prevention, especially since the disease often goes unrecognized despite being a major health issue in many regions. For primary prevention, we need to implement sore throat management programs in schools and communities to treat streptococcal infections early, reducing rheumatic fever risk. Educating people about the link between the common infections like sore throat caused by streptococcal bacteria and the risk of developing rheumatic heart disease, which can lead to lifelong disability or death if untreated. Using community health workers to educate families about rheumatic heart disease symptoms and antibiotic adherence, reducing stigma and improving the early health care will go a long way in reducing the menace of rheumatic heart disease. Promoting early diagnosis and treatment, which are vital to the progression for rheumatic fever to serious health complications, and but engaging community engagement and support to help improve disease management and foster solidarity among affected families and health workers is essential. Also important is to highlight the preventable nature of rheumatic heart disease and advocating better health care, especially in low research setting where the disease is most prevalent. We have two very important and eminent speakers, Professor Karthik from All India Institute of Medical Sciences and Professor Leslie from Africa, who would be highlighting the important and latest advances in the epidemiology, diagnosis, and management of this particularly very important disease, which is important for countries like us. Thank you very much for your attendance and patient listening. Thank you for participating in the symposium.
Thank you, Dr. Taghi, for those inspiring words and for emphasizing the relevance of rheumatic heart disease in our shared mission. Our next speaker is a distinguished academician and clinical cardiologist from India. We are pleased to welcome Dr. Ganesan Karthikeyan, Professor of Cardiology at All India Institute of Medical Sciences, New Delhi, and Executive Director of THSTI. He will speak on the topic rheumatic heart disease. What have we achieved in the century? Dr. Karthikeyan, please.
Uh, thank you, sir, and thank you to the CSI, especially Dr. Sotra, for inviting me to give this talk. It's a great honor and privilege for me. I'm going to share my screen.
Please.
Can you see my screen?
Yes, sir. So we can see it.
So I'm not going to pretend to know what has happened in the last 1 century. So I'm just going to say what we have learned in the last recent past. So that is, I'm just going to stick to what we have learned in the last maybe 20 or 30 years. So sorry, this is not moving.
So you can kindly double click.
Okay. So this is just a slide which you can make. Anybody can get this data. This is the global burden of disease data from, you can go to WizHub and just create these graphs. So here you can see that if you look at the deaths per 100,000 population in the 15 to 49-year age group, you'll see that across the world, across different income countries, there is a small reduction in deaths due to rheumatic heart disease over the years, over the last, say, 35 years. These are data which are compiled till 2022. So you'll see that the biggest contribution is from low and low middle income countries. Now, Dr. Tyagi also pointed to this fact that there is not much research in supporting rheumatic heart disease research, but you'll see that despite, so in the initial days when RHD was very an important problem in Western countries, say the United States and other countries, so there was some peak of research activity here, but gradually it just died down. But now you can see that a lot of research is happening on rheumatic heart disease, and I'm happy to say that much of this research is originating in places where the disease is endemic right now. So it is in India, Africa, and other places where it is actually endemic. So that is a very good thing. So I just want to start by saying what I think we have learned in the last 20 years. This is just my opinion. So I think there have been three big changes. The number one change is that we have now better data on disease burden, actually number of cases which are there, number of deaths. So you have better data now. Now we have also very good data on outcomes. So this was not there before. So we never had large prospective studies. So now we do have, in fact, we have randomized trials which provide us good information on outcomes in patients with rheumatic heart disease. And we also have now better data on prevention of progression. So I'm just going to touch upon all of these briefly, but I also want to highlight the fact that much of our thinking about rheumatic heart disease has been shaped by people who have been working in Australia and New Zealand, where they've been working on very small populations, maybe 100,000 people who are especially prone to rheumatic heart disease and acute rheumatic fever and rheumatic heart disease. So they have been driving the research agenda. They have been driving policy. So I think what we see is quite different. And I would like to present our perspective of how we should move towards controlling this disease. Now, how do we improve outcomes? So that is the primary question, isn't it? So how do we improve outcomes in patients with rheumatic heart disease? Again, these are graphs created from the GBD data. So if you see, I just took Southeast Asia because we don't have all the countries are similar in South Asia. So you can see that the deaths due to RHD, age standardized death, this is not age group specific, this is age standardized death. You'll see that it is reducing over time. So this is about a 2% annual reduction in deaths from 2000. So this is really not no real rheumatic heart disease control program is working right now. So this is despite the lack of a standard rheumatic heart disease control program, there is a 2% annual reduction in deaths. And like Dr. Tyagi pointed out, there is a lot of heterogeneity. So, for example, in the south of this country, there is hardly any rheumatic heart disease right now. So, if you do screening studies in South India, you don't get too much rheumatic heart disease. And so, similarly, this average 2% annual reduction is across the board. Now, if we have to really change this trajectory, this is a case of not doing anything. Even when you're not doing anything, you are able to reduce it by about 2% per year. But I don't think that is sufficient. So we need to really act on this. So how do we act on this? So if you look at the forecast, you can actually create these graphs for yourself as well. So how do we change this trajectory? So these are the latter part of this is the forecast. So this is the forecast. So you'll see that at this current rate, 2% reduction per year, you will not be able to reach. This is graphs for this is the line for high income countries. This is for South Asia. So you will see that even if we go at this rate, we are not going to be able to reach the high income levels by say 2047 when we want to be a developed nation. So how do we do this? I mean, what is the expected reduction? So we just need to increase the reduction in deaths from 2% to 4% per year. So if we do that, then we can actually reach that. So that should be our goal. Now, the question then is, how do we do this? So for that, we need to understand what is important and what is not important in case of patients with rheumatic heart disease. So you'll see that I initially said that our thinking about rheumatic heart disease has been shaped by what people in Australia and New Zealand thought, because they did most of the research in the initial part. So everything is focused on primary prevention in New Zealand, for example, and secondary prevention in Australia. But none of these strategies have really worked, and they're very expensive strategies to implement, and it is not possible to implement it at scale, especially for a country like ours. So these are data from the Remedy study, which Liesel and I were part of, and we had done this many years ago. So you'll see that in this, there were India was just one center, and most of it was from Africa. So you'll see that the death rate was about 8.5% per year. So over 2 years, about 17% of people died. These are patients, this is the hospital-based registry data, which means patients who regularly come to hospital with rheumatic heart disease, and they died at the rate of 9% per year, almost 9% per year. The other important thing, see, people have been telling us that it's so important to target stroke. So if you see, the risk of stroke in this population was quite low. It was 2.1% of adult patients with AF. And it's about 1% per year in patients with rheumatic heart disease and AF. So this is something which is a small rate. So you know that if the rate of stroke is 1% per year, so the uptake of anticoagulation in this population was about 30% or 40%. So we know that it was not effective anticoagulation. So this is practically without anticoagulation. So we know that when the rate of stroke is so low, the risk-benefit trade-off with any oral anticoagulation, particularly VKA, is very low. So this is not an area which we should really focus on. But unfortunately, we've been, like I said, our thinking has been shaped by what other people think. So we, in fact, did this is the Invictus study, Invictus trial. So this is the first large randomized trial that we did in patients with rheumatic heart disease, 4,500 patients. Don't look at the difference between rivaroxaban and VKA, but this Kaplan-Meier curve shows the mortality rate. So there was a difference in mortality rate, but that's not important. The mortality rate was pretty high. So you see the y-axis, the scale on the y-axis, and this is the Kaplan-Meier curve for stroke and systemic embolism. So you'll see that the rates are quite different. In fact, the death rate was about 8% per year, and the stroke rate was about 1.1% per year. So the important thing in these patients is, of course, the death rate. So patients with symptomatic rheumatic heart disease die at a very high rate. So this rate is quite high. It is much higher than other known cardiac diseases. So similarly, when we looked at the data for the Invictus registry, which is about 14,000 patients followed up for about 3 years, we found that about 5% of patients died every year. So this is all patients. This is not just AF patients. This is everybody. So you'll see that most of the deaths were cardiovascular and most of them were because of heart failure. Stroke deaths were actually quite low. So it was just about 0.2% per year. So the important message from all these studies, all these prospective studies, is that the death rate from symptomatic rheumatic heart disease is quite high, and most of the death is because of heart failure. So how do we change this? How do we improve these outcomes? So in the Remedy study, we had the opportunity to look at stratify the patients who were recruited. It was about 3,300 patients. So we had the opportunity to look at three different income categories. And when we saw that the lowest income countries had higher mortality and compared to the upper middle income countries and low middle income countries. So, and we didn't know what were the potential reasons. And one of the reasons was that we had history of having undergone valve surgery or valvuloplasty, and this was quite differently distributed between the three income groups. So this could be one of the potential reasons. So, but this was just past history. So we did not collect information on what happened to them during the course of follow-up. But in the Invictus registry, so we had this information. So you'll see that when we looked at the predictors of mortality in the 14,000 patients, we actually were able to show that although even prior valvuloplasty and prior valve surgery was protective, but undergoing valvuloplasty and valve surgery during follow-up also was protective. So clearly, one of the best ways to treat, it's a no-brainer, really. I mean, patients with rheumatic heart disease which are symptomatic are in heart failure and they need treatment for correction of their valve disease. So it is really a no-brainer, but we have not really acted on this. And the important thing to remember is in these patients, most of them were symptomatic. Just about 5% of people underwent surgery or valvuloplasty every year. So that is a real low uptake. It just speaks to the lack of access and lack of availability of surgery or valvuloplasty facilities. Now, that is one part of it. What about medical treatments? There is really not one single medical treatment that has been shown to be beneficial in patients with rheumatic heart disease. We just extrapolate from if somebody has severe MR, we say, okay, we'll give ACE inhibitors. If somebody has heart failure, we give diuretics. So that's just extrapolation from HFrEF or HFpEF. Now, digoxin has been used in rheumatic heart disease patients. About 30 to 40% of people in India, for example, doctors give digoxin to patients with rheumatic heart disease. So we decided to do this trial. And so now this trial is nearly complete. Last visit is scheduled for December of this year. And hopefully we'll be able to show whether digoxin, which is an inexpensive drug, can really improve, at least we believe that it will improve at least heart failure worsening in these patients, if not survival. So let us see how this goes. So, but it's important to look at other medical treatments for rheumatic heart disease. The third part is about preventing progression. So as of now, there was never really any data on secondary prevention. We assumed that giving penicillin to these patients would prevent recurrent episodes of acute rheumatic fever, and that would prevent progression. But this has never been actually documented or proven in any randomized trial. There were only 3 quasi-randomized trials, and they were not very good quality, and it is insufficient. So whatever we've been doing is based on biological plausibility. Now, this is data from the GOLD trial. The GOLD trial looked at giving benzathine penicillin, to people who had subclinical rheumatic heart disease. And this trial was done in Uganda. And when we designed this trial, we looked, so at the World Heart Federation, the first World Heart Federation criteria for diagnosing rheumatic heart disease, subclinical rheumatic heart disease, had also just come out. And so these were the criteria that we used in the GOLD trial. So the outcome was an echocardiographic progression at 2 years. So there was a substantial reduction in echocardiographic progression between the BPG and the control group. So this was highly statistically significant, and the number needed to treat was about 13. But the problem is that whether this is really generalizable to our practices. So if you see the adherence to penicillin in this study was more than 99%. So in real world practice, it's just about 30% or so. And the outcome was really only echocardiographic progression, although there were some clinical progression, but it was mainly echocardiographic progression. And we don't give benzathine penicillin to everybody. Like Dr. Tyagi initially pointed out, there are some issues with availability. So many people get oral penicillin. So what about oral penicillin? There is now a non-inferiority trial which is also going on, which is testing oral penicillin against BPG, but that might give us some information. But it is impractical for us to give penicillin to everybody that. So for this purpose, we need to actually screen the entire population of children, which is just an impractical thing to do. It can't be done for India, for example. How will you do? How often will you do it? It will consume, if you actually do a back of the envelope calculation, it will consume more than 7% of your entire healthcare budget just to screen for rheumatic heart disease. And then you have to give them penicillin, and the penicillin adherence should be nearly 90% for it to be really effective. So this is not an practical thing to do. So we need to look elsewhere. Also, it's important to consider that when patients already have rheumatic heart disease, clinical rheumatic heart disease, the predictors of progression and death and heart failure are not secondary prophylaxis. It is more about how severe the valve disease is at the time of presentation. That again makes sense. Penicillin may prevent some progression, but once disease is already set in, that's not the important thing to do. We need to really treat the valve disease. So that again brings us to the same thing that we concluded from the Invictus trial and registry. So these are data from the Remedy registry. So I just want to leave you with some thoughts about how we need to really relook at this from a different perspective. So what do we know about the pathophysiology of AF? This has not changed much in the last 50 years. So we know that some strains of GAS, when they infect the throat or skin, trigger an abnormal immune response in a small proportion of susceptible people. We don't know too much about who exactly is susceptible, but we have some idea, but we don't really know what are the real determinants of susceptibility. And what we know that it is possible that molecular mimicry is at play and autoreactive antibodies and cellular immune responses are triggered. They cause inflammatory lesions, and recurrences lead to progressive fibrosis. This is our thinking about rheumatic heart disease pathogenesis. And this is what we wrote in the Lancet in 2018. But this is a very simplistic view of looking at it. It may be true, but then we have not been able to arrest progression by any means in the last 50 or 70 years. So this is something which has bothered me for many years. So we thought about this for a long time. And so when you actually look at this, everybody knows, every clinician knows that the mitral valve is almost always involved in rheumatic heart disease. So these are data from William C. Roberts' autopsy series. So if you look at autopsy series, the mitral valve is 100% involved in rheumatic heart disease. And second most commonly involved where is the aortic valve. Third is tricuspid, and the pulmonary is almost not involved in routine patients. So if you draw a correlation between the transvalvular pressure gradient across a closed valve, you'll find that this R value, R square, is actually 0.98. So it's a really high correlation. Now, that makes us think that it is possible that, so why is the mitral valve more susceptible? It is possible that immune injury is necessary, but it's not sufficient to produce disease. So hemodynamics may play a role. So this is also supported by case reports. So you see that this is the case report of a TGA child who, when they developed rheumatic heart disease, it produced tricuspid stenosis, not mitral. So it's not something about the mitral valve that is important. It's about the pressure that the valve suffers. So isolated tricuspid stenosis has been reported. At least there are 3 case reports in the literature about in patients with TGA and rheumatic mitral stenosis. Similarly, you will see that tricuspid stenosis, even in normal patients, even in patients with regular rheumatic heart disease, normal hearts, otherwise, it happens only when there is tricuspid valve involvement, only when there is PAH. And in the presence of mitral valve involvement. Without mitral valve involvement, you don't get tricuspid stenosis in patients with a normally positioned heart. The other important observation is from a series from the All India Institute many years ago. So they used to do Ross procedure. Dr. Sampath used to do a Ross procedure for these patients, some of the kids with aortic valve involvement with rheumatic heart disease. So when they actually looked at the data, so out of 75 patients who had significant AR and had undergone Ross, 13 actually developed patients with rheumatic heart disease actually had significant degeneration. So 13 had rheumatic heart disease, and out of 13, 10 had histopathology, and they showed that there were histopathologic evidence of rheumatic lesions. And during this period of 2 years, only 2 had acute rheumatic fever. So there was a progression. So remember that the Ross procedure, the pulmonary valve, which is normal, is transposed to the aortic position, and these valves degenerated very quickly in patients who had rheumatic heart disease, aortic regurgitation due to rheumatic heart disease. So these are important considerations which make us think that hemodynamics also plays a role. So if you look at the experimental studies that were done on in vitro experimental studies, you know that the TGF beta is involved in vascular endothelial cell remodeling, interstitial cell remodeling, and TGF beta is activated in experimentally stressed vascular interstitial cell, which is similar to the transvalvular pressure gradient that happens in vivo. So what is the evidence for role of TGF beta? There are many studies which have reported that genetic polymorphisms of the TGF beta gene have been shown to be associated with more associated in patients with rheumatic heart disease. And evidence from histopathologic studies also suggests that there is a lot of TGF beta in the subendothelial stroma of valvular leaflets in rheumatic heart disease. So there is some data to suggest that TGF beta may play a role. We actually did a small study in which we looked at rheumatic mitral valves and 5 control valves at the All India Institute, and we did mass spectroscopy in these patients, and we found that TGF beta is much more represented in patients with rheumatic heart disease than in patients with controls in the control patients. So there may be an alternative mechanism for disease progression that may explain disease progression in patients with rheumatic heart disease. So autoimmune injury during acute rheumatic fever, epigenetic priming of the TGF beta signaling in valve cells happens, and valves which are susceptible, which have been exposed to high TVPG, are the ones which actually develop valvulitis, and then all these things that we already know get activated, and they produce valve disease. Valves with low TVPV, transvalvular pressure gradient, tricuspid and pulmonary valve, normally do not show any valvulitis unless they are exposed to increased TVPVG, like PAH or the Ross procedure, or in TGA situations. So this is an alternative mechanism that we recently published, and we said that TGF beta may play a key role in disease initiation and progression, and there is an easily available drug that can be used to prevent progression. So it is important that we test it in a randomized trial. There is also evidence from other situations. So these are models of myocardial infarction in which they looked at induced myocardial infarction, and then looked at mitral valve thickening in these patients. And patients who received losartan actually had, these are not patients, these are animal studies. So TGF beta inhibition reduced valve thickness, mitral valve leaflet thickness in these patients. So the idea is, let's bring fresh thinking to rheumatic heart disease. So we need, first of all, adequately powered randomized trials to test existing and novel treatments to improve outcomes. That should be the goal. We need to be open to alternative mechanisms. Our thinking has been focused, has been shaped by previous attempts at how this disease is being looked at by other people. So we need to look at it from our perspective. And now we have newer tools and approaches to understand pathogenesis and identify treatment targets. So, and the key thing is international collaboration. So this is one of the conditions which can be used for, where a platform kind of trial can be very useful, because we saw this in COVID. So we can test multiple treatments, and if we have an international platform of patients with rheumatic heart disease, we can really work this out. So this is just a picture from Kodaikanal in India. So thank you very much, and I'm happy to answer any questions.
Thank you, Dr. Karthikeyan, for an excellent discussion on what we have learned and giving us new perspective into the disease, which is subclinical but indolent in India. Now I am proud to say that as part of our Rheumatic Heart Disease Day celebrations, we are honored to present a special recorded lecture by one of the world's most foremost experts on rheumatic heart disease, Professor Lisa Julke. Professor Julke is a professor of cardiology at the Cape Town Heart Institute and chair of rheumatic and congenital heart disease for the Pan-African Society of Cardiology. She also serves as the president of Rheumatic Heart Disease International, a global NGO dedicated to fighting rheumatic heart disease. Her extensive research and advocacy has been instrumental in raising awareness about the global burden of rheumatic heart disease, particularly in low and middle income countries. Please join us in welcoming Professor Liesl Julke as we watch our enlightening lecture titled Global Burden of Rheumatic Heart Disease. Yes.
Greetings to everybody online today, and my sincere apologies for not being able to be with you. Thank you very much to the organizing committee for inviting me. It is an honor to be here, and I am glad that together we are celebrating Rheumatic Heart Disease Day. I'm going to speak to you about the burden of disease, of rheumatic heart disease. And firstly, I am Liesl Julke. I'm the Vice President of the South African Medical Research Council. I've been working in rheumatic heart disease for over 25 years. And it is a disease of poverty and inequality that reminds us of the consistent, catastrophic and persistent consequences of colonialism and in South Africa of apartheid. And as the SAMRC, we dedicate ourselves and recommit our capacities and our resources to the continued promotion of justice and dignity. So the global burden of rheumatic heart disease, well, this is the global burden of group A streptococcus, and some of you may have seen this paper before, which spoke specifically to the prevalence of rheumatic heart disease. This depiction in South Africa and in Africa galvanized researchers into multiple different projects and initiatives to combat what we could see here, the hotspots or the global hotspot of rheumatic heart disease. But this, of course, seems that the whole of Africa is a single has a single focus. The whole of India and Pakistan are all the same, as well as the rest of the continent. And we realize it's not quite like that. This was further followed by an excellent paper from Michael Seckler from 2015, where he looked at the worldwide epidemiology of acute rheumatic fever and rheumatic heart disease, but plotted these out as trends based on the number of papers. On the left, acute rheumatic fever, and on the right, rheumatic heart disease. And it definitely showed a difference in each of the WHO regions of the world. And very important, if you look at the blue, you got a sense of how much data there were. This is from the Western Pacific Islands. And if you looked at the sort of darker orange color at the top, the B graph, that is Europe. And so very little to be said for what was happening in those regions of the world. This was in 2016, David Watkins and colleagues. Again, Africa brushed with the same paint, and you can see endemic and non-endemic countries. But if you look a closer look, this is the DALIs of the same year, you can see the differences in the different countries across the globe. Very interestingly is to look at the different countries in Africa, but then also to look at the Pacific Islands, the various island nations of the world, Fiji and Tonga, off the coast of Australasia, having a very different burden of disease. And this particular graph speaks to disability-adjusted life years. This was followed in 2016 by another paper led by Jonathan Karapetis, and looked at two areas. One, the age-standardized prevalence, either in increase or decrease, and then the number of prevalent cases of rheumatic heart disease, and really showed us how granular these data points are. And so to say a particular region of the world is endemic means we actually are being very superficial, and we need to employ a much more granular approach. What we're dealing with now in terms of the most recent global burden of disease data is that we have about 50 million people living with the disease, about 350 die each year. This is 12.6 million Delhis. But of the importance is that 96% of these deaths still happen in low and middle income countries, and 70% of them are happening in those under the age of 25. So if we look at the geographic hotspots of the high burden, sub-Saharan Africa, South Asia, Pacific Islands, and then indigenous populations, either in Australia or New Zealand, but even in the high density areas in the US, and immigrant populations in Europe, low burden, high income countries, and this is thought to be due to antibiotics and easily access to them, better housing and stronger health systems. If we look at some of the projections, this is a very interesting paper from 2022, looking at the projections of global and regional RHD burden from 2020 to 2030. Very difficult and busy slide, but I think the most important thing to note is that areas above the line in pink are countries of the world where the trajectory in 2020 to 2030 is thought to be increasing, and that includes Asia and Africa. We are aware of the fact that even in countries like your own, where there has been significant improvements as well as important innovations in RHD, there is a continued burden of rheumatic heart disease. That speaks to a little bit about mortality and about burden. What about the health-related burden? And this is about mortality. This is about morbidity rather than mortality. One of the areas that often is not depicted in some of these graphs. The top right is a patient from Kenya, you can see, with very chronic mitral stenosis based on the Dopplers, and what this has done affected her lifestyle. And below that, a young child from Uganda that underwent surgery in Rwanda. The Remedy study, which is quite a few years back now, brought together 14 countries, 12 in Africa, as well as Yemen and India, to identify and understand the characteristics, complications, and gaps in evidence-based intervention in these countries. We looked at 3,500 participants, all of them prospectively followed, and what you could see is significant morbidity besides the mortality. So heart failure up to 33%, New York Heart Association 3 and 4, 24%, stroke 7%, congestive heart failure, again 33%, this is how they presented, pulmonary hypertension almost 30%, and atrial fibrillation 22%. This was the outcome of that particular study, where you could see over 27 months the number of events, in particular here, congestive cardiac failure, 204 events over that period. If we look at what that meant in terms of morbidity and mortality, death, 20% in the 27 months in low-income countries, low and middle-income countries, 16.8%, and in upper-middle-income countries, not that much less at 12.5%. What is very interesting is that that original 2005 paper used a number of 1.25% per year in calculating mortality, which when followed prospectively was 10 times more, even in high-income countries. Congestive cardiac failure, you see there the effect up to 10%. This is a more recent study led by my colleague and friend, Prof. Karthik. And this was just focusing on adults with rheumatic heart disease, and you can see again that remarkable and concerning in-hospital mortality for those hospitalized for rheumatic heart disease, as much as 37% in low-income countries, and a 30-day mortality of as much as 43% in low and middle-income countries. This is from Indonesia, wonderful study from Emiliana Sosanto, also following about 3,500 patients, and interesting difference here in Indonesia. So virtually the age was substantially higher. That was 44% was the median age. You can see again 64% women. And what was very interesting, and I'm not going through those data, but the medical coverage being different as well in terms of from private to public coverage. If you look at the central illustration and you look in the red box, the gender you understand, but what's so interesting is to see that the most dominant lesion was actually mitral stenosis in this group compared to what we saw in the Remedy study, where it was more mitral regurgitation in occasion together with mitral stenosis. If you look at secondary prophylaxis, you see very few people, only 23% of them were on regular prophylaxis, but 62.7% not having any prophylaxis at all. You may say that they are older participants, that's quite understandable, but the World Health Organization guidelines state that if you've got severe disease, you should be on prophylaxis, and with multiple mitral stenosis, this most likely counts. A little bit closer look at this particular paper. As you can see, there were 3,400 enrollments, and the vast majority of them were in atrial fibrillation. And you can see some of the other differences, intracardiac thrombus, you see there anticoagulation differences, of course, and then on the right, very interesting, the comorbidities, hypertension, diabetes, chronic lung disease, and coronary heart disease. Very important, because as you have an older population, you're also going to have these comorbidities. I'm turning now to global and national action to mitigate and address rheumatic heart disease. This is REACH, one of the only, in fact, the only that I know of, scientific and technical civil society organizations working together with communities as well as ministries of health to stop rheumatic heart disease. But we also have the WHO resolution that we've mentioned. I've put the REACH website there for you to engage with REACH. There are some model programs, particularly in Uganda, South Africa, New Caledonia, Fiji, and more we see integration with universal health coverage and NCD agendas. I mentioned the 2018 World Health Assembly resolution. Just to remind you, there were 3 parts of that. This was the focus on the countries living with rheumatic heart disease. This was a general, more international focus, and this was focused and directed at the WHO themselves. And if we put those, it spoke to a call to action, an invitation to collaborate with WHO and member states, and then requests of the WHO Director General. And one of the things that came out very strongly in all of this was the issue of equity and how we think about health equity, especially in the terms of rheumatic heart disease, and that according to the WHO, it's time to build a fairer and healthier world for everyone, everywhere, something that is particularly relevant when we think about Global Rheumatic Heart Disease Day. We know when we talk about prevention, there are 4 levels: primordial, primary, secondary, and tertiary. But a reminder that prevention is also about building a stronger economy, ensuring productivity, improved equity, a sustainable and resilient health system, which will then lead to reduced death and disease. When we think about primordial prevention, it is a great concern that we still have what we call multidimensional poverty. And when we look at this, it's sad to note that the countries that are RHD endemic are the ones that suffer the most in terms of multidimensional poverty. And this includes, as Nelson Mandela, our president, said, as long as poverty, injustice, and gross inequality exists in our world, none of us can and should truly rest. This is just taken from today, from World Poverty Map, able to see what the SDG 1, which is poverty, is in terms of being on track to meet the 2030 targets. And you can see Sub-Saharan Africa, South America, and again, some of the islands are all off track to be able to meet that SDG target. When we talk about primary prevention, we often think about treatment of sore throat or for skin disease. This is with penicillin. This hasn't changed in years, but this is the time to focus on a vaccine. There is the SAVAC. This is Strep A Vaccine Global Consortium, working to ensure that when a vaccine is available, it will be available for the countries that need it most. And part of the work here is sentinel sites. In Africa, there are 2 sites, in the Gambia and in Malawi. There is a site in India as well, and a site in Fiji. Moving a little bit to secondary prophylaxis and the use of secondary prophylaxis. This has probably been one of the biggest changes that has happened in terms of rheumatic heart disease in the last 15 years. This is the WHF criteria to ensure that we have an earliest possible diagnosis of rheumatic heart disease in order to institute secondary prophylaxis. The 2013 guidelines were published at the end of 2023, beginning of 2024, and linked the early diagnosis of rheumatic heart disease with heart failure. This is quite important because we now understand that secondary antibiotic prophylaxis, when administered for latent rheumatic heart disease, has a benefit in terms of failure to progress onto more severe forms of rheumatic heart disease. And this was led by Andrea Beaton and my colleague depicted there, Emmy Okello. The WHO guidelines, it was an honor to be part of this, was also recently published and addressed the whole pyramid of rheumatic heart disease, all the way from asymptomatic rheumatic heart disease all the way to death, and understanding that the interventions need to be pitched at the various levels. Finally, one of the most important changes, and it shouldn't have been, but is understanding the issue of meaningful engagement of those living with rheumatic heart disease, putting them at the center of the prevention and control agenda, as well as raising the profile of people living with rheumatic heart disease, which includes now human rights, social justice, prevention, treatment, care and support, and as I've said, meaningful engagement. So a couple of years back, there was this paper speaking about how do we generate global priority for addressing rheumatic heart disease. This was a qualitative policy analysis published in the Journal of the American Heart Association, and there were 3 major challenges raised. One was about leadership, second, solution definition, and third was positioning. And at the time, the comment was that there was singular leadership or individual leadership in the rheumatic heart disease space, which is not sustainable. The solutions were very varied, and we couldn't position ourselves because there were multiple silos. We find ourselves now, several years later, in a very different position with more diverse, equitable teams led by RHD endemic countries. We've been able to identify and address gaps in a much more scientific and systematic way. We've made global equity and human rights the center, and there's much more meaningful engagement with those living with and affected by rheumatic heart disease, which is truly the only way to decrease the burden. So my takeaways, rheumatic heart disease is entirely preventable, affects the poorest, youngest, and the most vulnerable. It reflects and suggests broader failures in health equity. However, there are exemplars of multi-country collaboration that have led to or will lead to global impact. One of our strengths is the significant long-standing partnerships that we have, and this is across the global RHD community, but I particularly am proud of partnerships between South Africa and India. And we know that there's locally led research, especially in these two countries. So future priorities must include translational research, community and lived experience partnerships, and then rapid advancements of skilled services such as cardiac surgery. And activism and advocacy remains key to driving down the global burden of rheumatic heart disease. So I thank you again for inviting me. And my apologies again that I'm not able to do this live, and I wish you very well. Thank you so much.
Thank you, Professor Julka, for that insightful and impactful lecture. Her presentation has truly highlighted the vast global burden of rheumatic heart disease and the urgent need for collaborative action to tackle the preventable condition. We hope this talk inspires all of us here to redouble our efforts in awareness, research, and patient care. We have some of our senior executive committee members like Chandravan Meena, Dr. P.K. Asakan, Dr. Suman Bhandari. I'd like to have their comments on today's program. And Dr. Asatra also. Your comments, Dr. Asatra? What I must say, you have done a great job.
Yes, the time was a little constrained. Catching hold of both the speakers was slightly difficult, especially Professor Julke was traveling a lot. She had to attend some 3 conferences on 2 different continents, but at least I was able to get her. She has really pioneered her work in Pan South Africa in the last 25 years in really advocacy of prevention of rheumatic heart disease. And it's good to hear from her. I think from Professor Karthik, I think we have new insights to look into some new goals or probably some new research areas. Probably we can start as something multicentric research, especially for looking to more of a hemodynamic injury, use of losartan, probably some trying to devise some randomized control trials. I think we can contribute to, as a country or as a nation or as some research centers, I think we can contribute to some of these new insights. I think.
Yeah, Dr. Bhandari, please. Dr. Suman Bhandari.
Yeah, so I'm sorry I joined a little late, but whatever I can speak is that do we have enough evidence that rheumatic heart disease in India is on the decline, or is it something still sort of not fully given out by sort of studies in the terms of its incidence, etc. And 2, I think all the underdeveloped countries have probably done the best work in rheumatic heart disease treatment and sort of trying to contain it. Streptococcus is considered the causative. Are there other theories as well? Like in the past, sometimes one felt Yersinia or rotavirus. Are there any doubts about other causative factors as well? That's what I wanted to hear again.
Thank you. Dr. Chandravan Meena, are you there? Dr. Meena, yes.
Yeah, good evening all, and it was a wonderful presentation by Madam. And as she highlighted, I think the most important part is the equity and availability of the health equity, especially in the underdeveloped and poor part of the poor society, state of the society. despite having India made so much of economic stride, still there are a lot of people who are in the state of abysmal presence. And I think we should focus more on the development of overall health status of the society. Then only we can contain. And the second point I would like to highlight is for the management of those patients who are affected, because this is the young generation and especially the generation who are more productive. I think both these are very important. And lastly, the development of the vaccine, if it is there, then I think that will be the best thing if it includes in the universal immunization program, especially in the underdeveloped countries.
Thank you. Thank you, Dr. Meena. Dr. Asakan, are you there? Dr. Asakan, are you there? I think he can't hear us. I have with us Dr. Diman Kali, our president-elect. Dr. Kali, can you put in some words, please?
So thank you very much, all the speakers. Wonderful disposition. And today we are celebrating on the occasion of Dr. Padmavati's birthday, and that's the happiest occasion we can do this movement. And I should tell that though not fully controlled, but yet we have partially controlled the rheumatic heart disease to some extent, but not to a great extent, I should tell. It's till now present, but in a country of 1.4 billion population, it's very difficult to eradicate one disease, but like rheumatic fever, and we know the horrible complications of rheumatic fever and the situation coming thereof. So we are all, as cardiologists, aware of that. And I think that within a short time, we'll be able to reduce further the incidence of this disease in the Indian subcontinent as a whole. And by immunization, by giving emphasis that every 21st day, they should take the injections, long-acting penicillin injection. And I should always also attract the attention of our learned professors and office bearers of Cardiological Society of India that this penicillin long-acting is somehow not available always in all parts of the country. So can we move something from our society to make it available? Because I think that if somebody takes the oral tablets, the immunity is not that much, the preventive aspect is not that much. But if we take an injection at least for 3 weeks, we will have a sufficient titer to fight the disease. So we need some movement from the Cardiological Society of India, just a representation to the central government. There is a very cheap drug, but it's frequently not available in many parts of the country. So make it more available and take a more realistic preventive strategy. And we are really hopeful that very soon we'll be able to control the disease to a large extent. Thank you very much, all the speakers, all the commentators, Professor Sanjay Tyagi and Dr. T.P. Sinha.
Thank you, Dr. Kali, for your kind words. And I'm sure during your presidency, you will take initiative for this particular pet project of yours. I've been hearing this from your side for a pretty long time. Now we have Dr. P.Q. Asakan. Dr. Asakan, we can see your name but cannot see you. Dr. Asakan.
Hello. Good evening, sir. Sorry, some technical difficulty. I could not join in between. It's an excellent talk, sir. And congratulations to the CSI and all the participants, all the speakers. And one thing I would like to say is incidence of rheumatic fever has come down, and the rheumatic heart disease, whatever the incidence prevalence in India has come down. Probably the hospital admission with the rheumatic heart disease has come down drastically. Second one is we don't have any recent population-based studies. What we have is now school-based studies, and we already initiated based on the echo rather than the clinical. We're going to pick up more of subclinical rheumatic heart disease. That's going to be the trend going to happen.
Thank you. Thank you, Dr. Asakan, for your words. Now it is my honor and privilege to deliver the vote of thanks on behalf of the Cardiological Society of India. as we conclude this important and inspiring session on Rheumatic Heart Disease Day. First and foremost, I would like to express our deepest gratitude to all of our esteemed speakers whose insights and expertise have enriched in this program. A special thanks to Dr. Sanjeev Asatra, convener of the CSI Rheumatic Heart Disease Council, for his warm and thoughtful welcome address, and also for his excellent organization of today's program. Dr. Sanjay Tyagi, President of Cardiological Society of India, for highlighting the importance of the day and reminding us the enduring legacy of Dr. S. Padmavati, whose pioneering work continues to guide us. No word of appreciation is sufficient for Professor Lisa Jurke, who, despite her immense workload, has taken time out to present her powerful and data-driven talk on the global burden of rheumatic heart disease. A timely reminder that our work must continue across borders with global collaboration, with equity and dignity for everybody. Professor Ganesan Karthikeyan, for his brilliant analysis on what we have achieved in this century in the field of rheumatic heart disease, and for urging us to look forward with renewed energy and focus. We are deeply thankful for your presence and valuable contributions. Today's program was not only a tribute to Dr. S. Padmavati, a legend in Indian cardiology, and also a true inspiration to all of us, but also a reaffirmation of our collective commitment to eliminating rheumatic heart disease. Her achievement being the first woman president of CSI in 1965, the recipient of Padma Bhushan and Padma Vibhushan, and a CSI Lifetime Achievement Awardee will always be a source of pride and motivation for us. We are pleased to report to you that around 400 delegates from across the country has joined us today through virtual platform. Your participation adds great value to this initiative and reaffirms our collaborative commitment to tackling rheumatic heart disease together. Let us move forward with a renewed commitment to awareness, prevention, and care, so that one day rheumatic heart disease will no longer be a public health concern in our country or else anywhere else in the world. Thank you once again, and wishing you a pleasant evening. Long live CSI. Long live.
Thank you.
Thank you.
Thank you. Thank you, everybody.
Sanjeev? Dr. Sanjeev? Dr. Sanjeev?
Yes, sir. I am here, sir. Right.
Yeah. From the behalf of CSI, can you send a small survey type of thing on rheumatic heart disease to different medical colleges, whether on the questions that have been raised, like is the rheumatic heart disease decreasing?
Surely, sir. Surely. I'll design
the availability of penicillin, then we can represent to the government on behalf of CSI that this is the problem and that we should eradicate.
Surely, sir.
Simple questionnaire, and we can compose the data and then send to the government.
Right, sir. Right, sir. It's a very, very good idea, sir. I think it can be done. So I'll try making a questionnaire.
Yes.
And I think
just send email to the medical colleges and find out
surely,
about the availability of benzathine penicillin, oral penicillin also.
Okay, sir. Okay.
Oral penicillin V was not available. I don't know what is the situation now.
No,
and the acute rheumatic fever cases, are you seeing some acute rheumatic fever? Is there seeing the decline? Just simple questions.
Okay, sir. Okay, surely, sir. Surely.
That will be great, useful.
Okay, sir. Okay, sir. It can be done, sir.
Thank you, everybody.
Okay, sir. Thank you very much, sir.